Childhood asthma. The objectives of this lecture are to understand the natural history of asthma during childhood, be familiar with the key features of history and examination that support the diagnosis of asthma, be able to manage an acute exacerbation of asthma, know the details of drug used to treat acute and chronic asthma, know the guidelines for the management of asthma, and be able to advise parents about how to care for a child with asthma. Asthma is a chronic inflammatory condition of the lung airways, resulting in episodic airflow obstruction. This chronic inflammation heightens the airway's hyperresponsiveness to propagative exposures. The epidemiology of asthma. Worldwide, childhood asthma appears to be increasing in prevalence, despite considerable improvement in management. In 56 countries, found a wide range in asthma prevalence from 1.6 to 36.8%. Approximately 80% of all asthmatics report disease onset prior to 6 years of age. Risk factors like history of other allergic conditions like allergic rhinitis, allergic conjunctivitis, atopic dermatitis, food allergies, and parental asthma and/or symptoms apart from cold support the diagnosis of asthma. This figure shows two types of wheezing children. The blue line shows the transient early wheezers. These children start wheezing early in infancy and continue to have recurrent wheezes until about the age of 3 years. And the other curves shows IgE-associated wheezing or asthma in children who tend to have persistent recurrent wheeze after the age of 3 years. With the genetic predisposition of children with asthma, there is usually a history of atopy and environmental triggers. The environmental triggers might include upper respiratory tract infections, allergens like host dust mite, grass pollens, pets, smoking, active or passive, cold air, exercise, emotional upset and anxiety, chemical irritants like paints and aerosol. These three factors will trigger bronchial inflammation in the form of edema, excessive mucus production, infiltration with cells, eosinophil, mast cell, neutrophil, and lymphocyte. This will result in bronchial hyperresponsiveness, exaggerated twitchiness to the inhaled stimuli, where airway narrowing, reversible airflow obstruction, and peak flow variability will be seen, and result in symptoms of wheeze, cough, breathlessness, and chest tightness. Intermittent dry coughing and/or expiratory wheezing are the most common chronic symptoms of asthma. Shortness of breath, which is worse at night, and daytime symptoms often linked with physical activity. For the investigations, lung function tests, when the child is old enough to perform them, usually at the age of about 6 years and above, confirm the diagnosis of asthma and determine the disease severity. Chest X-ray often appear to be normal, but hyperinflation and peribronchial thickening are characteristic findings of chest X-ray in asthmatic patients. Atelectasis, pneumomediastinum, and pneumothorax may be seen. CT scan is rarely needed in asthma. Allergy testing assess sensitization to inhaled allergens and help with the management and the prognosis of asthma. 80% of asthmatic children had inhaled allergen sensitization by allergy skin prick testing. There is a rule called the three strikes rule. Divide the patients into two groups, either intermittent asthmatics or persistent asthmatics. If the patient has daytime asthma symptoms at least 3 times per week, or awakens at night due to asthma at least 3 times per month, or experience asthma exacerbations that require short course of systemic steroid at least 3 times per year, he is in the category of persistent asthma. Here, he might be mild persistent asthmatic, moderate persistent asthmatic, or severe persistent asthmatic. If he cannot achieve the 3 strikes of this rule, he is considered as mild intermittent asthmatic. This differentiation is very important when we plan treating the patient by controller therapy. According to the guidelines of controller therapy in asthma, daily controller therapy is not recommended for mild intermittent asthma, and to treat all persistent asthmatics with anti-inflammatory controller medications. Daily inhaled corticosteroid therapy as the treatment of choice for all patients with persistent asthma. Inhaled corticosteroid therapy reduce asthma symptoms, improve lung function, reduce rescue medication use, reduce urgent care visits, hospitalizations, and prednisolone use for asthma exacerbations by about 50%. Short-acting beta agonist therapy is recommended for intermittent and persistent asthma, as it is a quick reliever medication for symptoms and exercise pre-treatment. For controller therapy, for mild persistent asthmatics, the preferred treatment is low dose of inhaled corticosteroid. The alternative to this is leukotriene receptor antagonists or theophylline, and theophylline given for patients more than 5 years of age. For moderate persistent asthmatics, if they are young children, the preferred treatment is medium dose inhaled corticosteroid alone. The alternatives is leukotriene receptor antagonists. For older children, the preferred is combination of low to medium dose of inhaled corticosteroid with long-acting beta agonist. The alternative is leukotriene receptor antagonist or theophylline. For severe persistent asthmatics, high dose of inhaled corticosteroid is needed. Long-acting beta agonist and oral corticosteroids sometimes needed. Leukotriene receptor antagonists like montelukast and zafirlukast, they decrease the need for rescue beta agonist use in children. And the long-acting beta agonist, the LABA, salmeterol or formoterol, they are daily controller medications and should not be used as monotherapy. The other non-steroid anti-inflammatory agents used in asthma are cromolyn and nidocromil. They can inhibit allergy-induced asthmatic response, and they reduce the exercise-induced bronchospasm. For theophylline, it's an alternative monotherapy controller agent for older children and adults with mild persistent asthma. It's no longer considered the first-line agent for small children. The short-acting beta agonist, albuterol, which is salbutamol, levalbuterol, terbutaline, they are the first drugs of choice for acute asthma symptoms, called rescue medications, and in preventing exercise-induced bronchospasm. The anticholinergic drugs, like ipratropium bromide, They are much less potent than beta agonists. The inhaled ipratropium bromide is primarily used in the treatment of acute severe asthma. When used in combination with albuterol, ipratropium can improve lung function and reduce the rate of hospitalization in children who present to the emergency department with acute asthma. The home management of asthma exacerbation include immediate treatment with rescue short-acting beta agonist, a short course of oral steroid therapy, injectable forms of epinephrine might be needed, with portable oxygen at home in severe cases, and call for emergency support services when needed. The outlines of emergency department management of asthma include close monitoring of clinical status, hydration and oxygenation, inhaled beta agonist, systemic corticosteroid use, inhaled ipratropium bromide, magnesium sulfate, intramuscular injection of epinephrine or other beta agonist, intubation, and mechanical ventilation. Recurrent coughing and wheezing occurs in 35% of preschool-age children. One-third continue to have persistent asthma into later childhood. Two-thirds improve on their own through their preteen years. It's said that entire wheeze isn't asthma, but when it recurs, it is. And asthma does not always wheeze. Thank you and good luck.